So this is a huge topic with personal injury. And so let me just remind you that when we do the narrative report, remember the narrative report is the single most important document in the personal injury. So we go, okay, do you have to know the 12 categories? Yes. Do you have to know the relationship of what category? You definitely have. Yes. So again, what are the 12 categories? So let's go big picture to small picture. And then I want to point out 3 or 4 very important findings that you must include in all your narrative reports, and especially this topic right here. Is, you have to be able to explain what causes pain, why somebody has pain and has no pain in some ranges of motion, yet some pain in other, or why they have pain, don't have any pain, maybe in the first 50 to 70 degrees of a range of motion, but only at the end of that range of motion. So you got to be able to explain this. This is unbelievably important for the soft tissue spinal injury, but there's about 3 major categories you have to know in addition. So remember, when you go to the big category, it's the overall big category for everything. It's the mechanism of injury, injury magnifiers, subjective findings at MMI, hybrid findings at MMI, objective findings at MMI. The therapeutic protocol was based on the patient's biomarkers relative to the science of the 3 phases of healing. What was the response to treatment? What was the complicating factors? Did they reach MMI? Was there an impairment rating? And what was the prognosis and need for future care? And if there was any pre-existing injury, apportion the pre-existing injury. So those were the 12 categories. And then you go, okay, out of those 12, what are the 7 most important categories that's going to determine your injury award that you absolutely have to have? Mechanism of injury, yes. Injury magnifiers, no. Those are supplemental. Subjective, yes. Hybrid, yes. Objective, yes. MMI, yes. Impairment, yes. Prognosis and need for future care, yes. Those 7 categories are the most important 7 categories that support the injury award. Mechanism of injury, subjective, hybrid, objective, MMI, impairment rating, prognosis. You have to have the documentation, what we call primary or secondary factors, documentation in those 7 categories to make it, that's when you're going to have a decent injury award. If you do not have those categories, you do not have a good case. Okay, then we go into it when we say, when we have those 7 categories, and this is what I talked about today, was how many primary diagnostic evidence do you have within each category? The more primary categories, the better. How many secondary categories do you have supporting the primary? Well, the more you have, the better. How many different categories of diagnostics do you have supporting the evidence? Well, the more different categories you have, the better. See, these are the degrees which increase or decrease the strength of the injury award. So this is all in the narrative report. So remember, what are some of the major topics outside of what I just covered in the narrative report? Number 1, the 3 phases of healing. And all care is based on it. And that's essentially what sets up you being able to explain why the patient has pain or discomfort or restricted activities of daily living that are permanent. So that is unbelievably important. So 3 phases of healing. What else is real important? Being able to explain MMI, unbelievably important, relative to the 3 phases of healing. How to give the impairment rating is real important. That's based on the MMI and the 3 phases of healing. And remember, you should have the documentation to support all this. And then you have the impairment indexes. The impairment indexes are vital because they show the pain and restrictions with activities of daily living. So having said that, and then of course, the prognosis, the need for future care. But when we go inside these categories, the 3 phases of healing, important. the negative aspects of healing from the three phases of healing, how to explain that the person has a permanent problem. That's MMI and the three phases of healing. And then, of course, we gave the impairment rating. Then there's the impairment index, and then the ADLs. Remember, the ADLs are unbelievably important. What pain or restrictions that they have with the ADLs, where they're definitely going to have some, and this is where you have to be good in collecting your ADLs. You don't want just all your ADLs and all ranges of motion to be positive, because that's not trustworthy. So you want to make sure they're very clear and they're very specific to that patient's injury. So if, in other words, if they have trouble primarily in extension, well, then you need to be finding positive ADL restrictions in extension, especially overpressure, which also means that you should definitely have normal findings in flexion or even left or right lateral bending. In other words, you don't just have gross positive findings. The positive findings should be geared toward and focused on the mechanism of injury or the plane of the injury. That gives credibility when you say, yeah, the patient doesn't have any pain or restrictions with this activity in flexion, but they do in extension. And oh, by the way, the first 50 degrees of extension, they don't have any pain or restrictions, and this is why. But after 50 degrees, they do, and this is why. See, that is gold, to be able to explain that. And then the other category is the phases of spinal degeneration. You always want to include, where is this person in the phases of spinal degeneration? It's another major category, because usually they accelerate. Usually they jump one or two categories once they have altered spinal biomechanics. They're going to have accelerated spinal degeneration. And then you always want to reference how does that spinal degeneration, how does it affect the different tissues? How does it affect muscle, nerve, tendon, ligament, cartilage, bone? See, those are generic statements. And then referencing how that injury is the number, that's pathological spinal biomechanics is the number one cause of the number one disability in the United States, osteoarthritis. Those are all major categories. So in this particular one, we're going to cover again how to explain when the patient has no pain or they do have some pain with different ranges of motion and activities of daily living. So remember the negative aspects of healing in the repair phase. There's the increased nerve sensitivity. So again, what does that mean to the patient? They have increased nerve sensitivity. When they do their normal activities, they're more prone to pain. Number two, there's an increase in the number of the peripheral regenerative nerves. It's called hyperinnervation, reinnervation. Just because there's more nerves in the same volume area, there's more likelihood of pain with compressive and tensile forces. Those are two good words to remember. Because remember, everything's dynamic that we're talking about. So we're talking about compressive and dynamic forces. Well, if I have more nerves in the same volume area and I add compressive or tensile forces, I'm going to have pain quicker than when I did not have as many nerves, just from the sheer physical compression of the nerves. So that's nerve sensitivity, increased number. Number three, the nerve category, is if the nerves get trapped in the collagen scar tissue. So those are the three origins. And so again, what happens to that matrix of nerves is, well, there's not as much compression or tensile forces if the patient is stationary. And if they move a little bit, there's a little more compressive or tensile forces, but not much. The further they move, bend their head, flexion, extension, whatever problem, whatever plane of motion they're having their problem in, and it's usually extension, then that those compressive and tensile forces increase as the patient's head continues to go back further and further into extension. Well, what happens when those compressive and tensile forces increase? What happens to the nerves that are more sensitive? What happens to the nerves that have an increase in the number of nerves? What happens to the matrix, the collagen matrix, the further back the patient bends? See, all of these increase the magnitude of the compressive tensile forces. And that's why a patient can be totally pain-free in a neutral position, have totally normal range of motion in, say, flexion or left or right lateral bending, and even normal, no pain or restrictions bending back, maybe until they hit 70 degrees. But from 70 degrees all the way back, say from 50 back, now they can't. And whatever activity is associated with that, they can't do anymore. Whatever activity of daily living they can't, whatever that is, shampooing their hair, sleeping, bathing, showering, cooking, work, cooking, cleaning, laundry, household maintenance, landscaping, gardening, hobbies. See? And so, and remember, all of these activities of daily living, for the most part, will engage almost all three ranges of motion, active, passive, and joint motion, to different degrees depending on the activity of daily living. So you may have one activity of daily living that there's more cervical extension involved. So you have a higher likelihood of having more pain and restrictions with that activity of daily living, as opposed to an activity of daily living that doesn't involve as much cervical extension. So maybe they just feel it a little bit for that narrow window that their head goes back past 50 degrees and in overpressure. So that's why they don't feel it as much. But that's also why they have no pain or restrictions when they bend forward or to the left or to the right. Okay, so unbelievable that you make sure you know that, are familiar with it, and can explain it. And so this is a very good generic statement here. It says why patients with permanent injuries have normal active range of motion, pain and restrictions with ADL and overpressure joint motion. So I go into it, says this is a very good generic statement. It says all injuries go through the science of the three phases of healing. So we identify the inflammation, repair, remodel phase. Major points to the three phases of healing. Each of the three phases of healing is physiological different. The goal in therapeutics is to restore the specific physiology for each phase. If the healing occurs abnormal, the patient will suffer permanent injury to some degree. Each healthy joint has three ranges of motion: active range of motion, overpressure, joint motion. So it's explained. The four most common factors that patients heal wrong or suffer permanent injuries to some degrees are age, how long they've had the problem, complicating factors, proper therapeutics applied to specific to each phases of healing, or just the severity of the injury itself. So permanent problems associated with each phase of healing when we heal wrong and what it means to the patient. So now we're just getting more specific. Abnormal healing in the inflammation phase leads to chronic irritation. Patient's permanent problem, pain and chronic inflammation in any or all three ranges of motion. Okay, so what happens in the repair phase when they go wrong? Abnormal healing, and I'm just going into each of the, I'm just breaking down each of the categories that happens. So what if there's abnormal healing with increased nerve sensitivity? Well, the patient's permanent problem, they'll have pain in all three ranges of motion, least compressive motion and active range of motion, most pressures and overpressure. That's what I just talked about. The least compressive is actually a neutral motion. And then it starts, the compressive tensile forces start increasing as the patient moves in a particular range of motion, with most of the compressive tensile forces occurring in overpressure or joint motion. So that's abnormal healing due to increased number of the new nerves. Patient's permanent problem, pain in any or all three ranges of motion. Least compressive pressure, again, is neutral, active, most pressure, overpressure. Because again, we're dealing with, those are the two words you got to keep in mind: tensile compressive forces. And so what if you have abnormal healing in the repair phase with new nerve growth? Nerves get trapped into new collagen or scar tissue, pain in all three ranges of motion, least compressive, neutral, active, most pressure, and active. See, it's pretty straightforward. I'm just sharing each of the negative aspects of potential healing and if it heals wrong, and what are some of the common expectations with the patient. Well, they're going to have more of whether the nerves are increased in sensitivity, increase in the number, or they get trapped. It's going to increase with the likelihood of compressive or tensile forces and decrease with less compressive force, such as neutral or in a plane of motion that's not injured, such as flexion maybe. So then I go to the remodel phase and do the same thing. Abnormal healing, new collagen formation forms in non-striated matrix, only 75% is strong. What does that mean to the patient? They re-injure themselves with normal activity. Least strain with normal range of motion, active range of most with overpressure and joint motion. That's where the injury will occur. Abnormal healing due to new collagen formation is only 75% elastic. So if it heals permanently wrong, joint stiffness, where? Well, primarily in overpressure and joint motion. Why? There's less stress in neutral active range of motion. It increases toward the end of active range of motion, and the most stressed is in overpressure motion. See, this is a very good generic form that explains this. You need to be able to explain it to talk about this, and it's unbelievably important. So when patients perform activities of daily living, they go through each of the three ranges of motion to some degree, depending on the activity. Almost every activity of daily living will take a person through all three ranges of motion to different degrees, depending on what activity you're talking about. So each of the three ranges of motion have different stress and compressive forces. The higher tissue stress and compressive forces, the greatest the likelihood of nerve irritation or compression. Collagen stress or compressive forces. The stress or compressive forces will determine the potential for nerve irritation, compression, collagen failure, or collagen elasticity. So the three ranges of motion relative to the stress and compressive forces. Active range of motion, I should have included neutral, because neutral has the least amount, meaning you can be totally pain-free because of these factors. So active, in the beginning, you have the lowest amount of compressed and tensile forces, and the more you go into a plane of range of motion, the more it increases. So the more the likelihood of it affecting those negative factors. Overpressure, it's real high. High potential stress, high potential compressive forces. Joint motion is very high. So you got to kind of think about this as in three dimensions. It's not black or white. And see, this is when it becomes very valuable when you know how to isolate that injury, that mechanism of injury to a certain plane of motion or one or two planes of motion. And you can differentiate that from the other planes of motion that are normal. And then within that one plane of motion, you can explain why they have no pain in neutral and maybe no pain in the first 10 or 20 or 30 degrees of active range of motion. That's unbelievably gold when you know how to explain that to the attorneys, and therefore you can explain it to a jury. And remember, you've got all the documentation in all the major categories to support this. This is when you become unbelievably valuable in depositions and trial testimony. So the four factors why patients with permanent injuries have pain-free and full active range of motion and painful restricted overpressure motion or joint motion during activities of daily living. So active motion is the least potential stress. Active motion is the least potential compressive forces. Active motion is the least potential for strength testing, so really I should have included neutral first, and then it accentuates with active motion, starting out slow with compressive tensile forces and slowly increasing until it gets toward the overpressure range of motion in that category. And that's why, and of course you have the diagnostics, you have all seven categories. You got the mechanism of injury. At least you're going to have the subjective correlative findings. You should have the hybrid correlative findings. You should have the objective correlative findings. And then you've got the patient at MMI, which gives the impairment rating and the prognosis and need for future care. And now you can explain, you can connect this injury to a permanent impairment, to permanent restrictions and activities of daily living the rest of that person's life. And it's all science-based, and it's all based on multiple biomarkers that all point in the same direction. Unbelievably important. This is when the attorneys give you a lot of business and want you to do and want to go to trial for a lot of cases because they know they can make a lot more money going to trial. But what's the problem? They can't find doctors that know this. Now, they don't even know it. Remember, they're in a state of unconscious incompetence. They don't even know this information exists. And that's why personal injury attorney educational sales is so important.